Hi, welcome to this GSA Momentum Discussion, Trends in Comprehensive Obesity Care for Women as They Age. This GSA Momentum Discussion highlights topics experienced by women and is sponsored by Novo Nordisk and Haleon. We thank Novo Nordisk and Haleon for their support of this program. I am Dr. Rebecca Allen. I'm a professor of psychology and the executive director of the Alabama Research Institute on Aging at the University of Alabama in Tuscaloosa. I'm a licensed and board certified geropsychologist and a fellow of GSA. Very fond of my GSA. My research and clinical interests are interventions to reduce the stress of individuals and family members in the context of chronic or terminal illness, medical and financial decision-making, particularly among dyads and aging families, and then finally, clinical training issues centering around community empowerment and substance use disorders.
Yes, thank you so much, and it is an honor to be here. My name is Catherine Starr. I am an associate professor in the Division of Geriatrics at Duke University School of Medicine and a research health scientist at the Durham VA. And my research has really encompassed the intersection of exercise and nutrition interventions for our individuals throughout their lifespan, particularly in that midlife to older age of obesity, and ways in which we can use those interventions to help ensure the maintenance of muscle quality and function and independence in our individuals. So really excited to be here today.
Me too. It's great to be here. I'm Dr. Angela Fitch. I am the co-founder and chief medical officer of KnownWell. I am also the past president of the Obesity Medicines Association. I'm a clinician scientist on obesity. I'm board certified in internal medicine, pediatrics, and obesity medicine, and have been taking care of people with obesity for the past 20 years. So thanks for having me.
Thank you very much for the opportunity, and thank you, the GSA, for having us all. And I am Anna Fender, and I am an assistant professor at Indiana University. I am board certified in family medicine, geriatrics, and obesity medicine. Thank you very much.
Okay. So as we know, obesity is a chronic condition with broad health implications. When paired with age-related changes in other conditions, it adds layers of complexity, especially for women. Obesity in aging women is a complex health challenge influenced by hormonal shifts, decreased metabolism, and changes in body composition, which worsen metabolic and inflammatory issues. An individualized approach is crucial, leveraging an interprofessional team and evolving treatment options to address these unique needs. Effective obesity care for aging women requires moving beyond a one-size-fits-all approach to a model that is personalized and considers the full range of physical, psychological, and social factors. An interprofessional team can provide comprehensive and coordinated care. Today, we'll talk about how interprofessional teams can adopt a personalized, evidence-based approach to obesity care and explore how treatment options are evolving to meet the needs of aging women. Dr. Starr, what changes in body composition and metabolism do aging women with obesity face?
It's such a great question. And I think, kind of just starting out by saying a lot of times the perception is the number on the scale tells the full story. And I think we have to take a step back and say that number on the scale really is telling a fraction of what is actually happening. So as we think about body composition and metabolism with aging in combination with obesity, what we know is we start to see something that happens with everyone as we age. We start to see lean muscle mass loss with aging, where we have our peak muscle mass around the ages of 30, 40. And then from there, we'll see around an 8% decline of a muscle mass loss after the age of 40. And then that accelerates to around 15% loss after the age of 70. Now, why is this important? Well, this is important because when we have that obesity component, we're now adding in that loss of muscle mass with this added adiposity, which really creates this environment for the inflammatory process. Again, when we start to get down to really what's happening at the muscle level, we know that we start to see more intermuscular adipose tissue. So muscle starts to infiltrate, or fat starts to infiltrate the muscle. So that naturally occurs with aging, but it's going to be accelerated when we start thinking about our individuals with obesity, our women with obesity. So we have that component that happens through these physiological changes. In addition to that, we also start to see this decline in muscle strength. So we will see a decline in muscle strength along with a decline in our bone mineral density. So that all, again, a part of the aging process. And then again, with obesity, we're going to start to see this accelerate this process. So we're putting our older adults are at greater risk for sarcopenic obesity and ultimately a decline in physical function. So we have these physiological changes that occur. In addition to that, we also start to see this reduction in our resting energy expenditure. So the amount of calories that we actually need goes down, and that's a result of those physiological changes. We see a reduction in fat-free mass and increase in visceral and ectopic fat around our central adiposity and around our organs. So with that acceleration of the fat mass, reduction in lean muscle mass, calorie needs go down, but most of us aren't changing what we're taking in. And so that's where we start to see this increase in energy intake, adding into more ectopic fat, resulting in that insulin resistance, and then how that ultimately impacts our muscle health again. So it's this really big cycle that we see with obesity, aging, and ultimately potentially can lead to sarcopenic obesity. So really at the end of the day, I think it's just important for us to understand again that the number is not telling the story. What is really telling the story and what we really have to be focusing on is that body composition component. What is happening from a physiological and metabolic standpoint from the aging process, and we'll talk about the hormonal changes too, but from the aging process and then that added inflammatory response that's occurring because of the extra adiposity. So much more important for us to be thinking about our patients from the standpoint of functional capacity, how we're feeling, how we're actually able to move, rather than what is the number on the scale and how that's going to actually ultimately impact functionality.
100%. Thank you for that.
I'm a huge fan of body composition. I believe that we should have body composition devices. We have a body composition at all of our centers, a bioimpedance analyzer. And I realize that DEXA is considered, still the gold standard, although I think that should change, to be honest. It's very impractical to even do DEXA in research. It's hard to do DEXA even in research, let alone hard to do DEXA for actual clinical care. And so I think bioimpedance now has gotten to be where it's 97% as sensitive as DEXA scan. So why are we nitpicking over 3%?
Absolutely.
When we could get all this data and everybody could know their body composition and know, not from a stigmatizing thing, but from a I understand where I'm coming from, and then I understand where I'm gonna, where I need to go.
Absolutely. And how that changes over time.
Yes.
Knowledge is power. Yeah.
That's what I think.
Yes.
I'm a huge body composition fan.
Completely agree. Dr. Fitch, how do hormonal changes associated with menopause interact with excess adipose tissue to promote systemic inflammation and accelerate other chronic health conditions such as heart disease and diabetes?
Yeah, so for women in general going through menopause, right, we lose our estrogen, we lose our testosterone, we lose our progesterone, but most importantly probably is that estrogen, that loss of estrogen. And then, that leads to insulin resistance, which then leads to, as was mentioned, increased visceral adiposity. And it's that increase in that visceral adiposity then that leads to that, typically that inflammatory fat or that metabolically unhealthy fat deposition that then, leads to this inflammation cascade, which then contributes to cardiovascular disease, contributes to, increased risk of diabetes because of the insulin resistance. So all in all, our loss of our female hormones in particular are the ones that are really, driving a lot of that increased risk of cardiovascular disease and diabetes as we age, which is unfortunate.
Okay, thank you very much. Dr. Pendry, how does excess adiposity, especially visceral adiposity, link to heightened risk for other conditions in postmenopausal women?
Yes, so thank you for that question. Very important question, because as we age and as our estrogen declines, then there's hormonal changes, insulin resistance, more hormones such as ghrelin appear in our body. And so all those changes and this accumulation of visceral adiposity predisposes us to diabetes mellitus type 2, but also to cardiovascular disease, hypertension, dyslipidemias. And we also start seeing that with this increase in adiposity, we also can have muscle mass loss and also infiltration of this muscle with fat that can take us to sarcopenic obesity. So we start losing functionality. So then we have to find the sweet spot where we want, as women, to preserve our functionality, independence, quality of life. And what is the sweet spot of having weight loss, preserving muscle mass, but also preserving functionality and quality of life?
Oh, I love that. It's so important to really think about the function of weight loss and support living independently in the community, right? Mm-hmm. Independent living capacity is huge. So really appreciate that. Back to you, Dr. Fitch.
Okay.
How can clinicians accurately assess and track physical function and mobility loss in women with obesity as they age, moving beyond simple BMI measures?
Yeah, so we've always advocated in general of moving beyond simple BMI, even as we talk about weight management, so even not about physical function, but, as was mentioned, it shouldn't be about a number on the scale, right? And so often it has been about that number on the scale, because I think, especially as women, there's this ingrained feeling that I need to weigh this much, I need to be this much. And so I think, we have to get away from that. We tell our patients all the time, we want to be leaner, not lighter. Because people come in, they think they want to be lighter, but what they really want to be is leaner. If I told them they could weigh the same amount and look like, I don't know, name a sports professional person, Michael Phelps or something, like we know what he looks like, and if you looked like that and weighed 200 pounds, you're like, I'd be fine with that, But the thing is that most of the time it's not about, being lighter. It's really that we want to be leaner, more compact. We want our clothes to fit better. We want to move better. We want to move around better. And so I think, really focusing on this sort of not so much measuring something in clinic, like with grip strength or sit to stand testing or walk testing. There's all sorts of functional testing we should do. And we probably should maybe do more of that in clinic, to have some, so we can track outcomes a little more scientifically. But I think ultimately also asking people, right? Like at baseline, when you come in and you want to lose weight, we do this all the time with our patients too. We say, well, what is your single most important outcome, right? Yes. What are you trying to achieve here? Is it really that you're trying to be 120 pounds? Or is it really that you want to be able to ride the roller coasters with your grandkids or with your kids, or, fit in a seat better on the airplane because you're tired of using the seatbelt extender? There are various reasons, and we have to, come back to that function, versus just those numbers. And so I think, asking patients, we've started asking patients on our questionnaire, like, can you carry a sack of groceries, up one flight of stairs and if you can't, why can't you? Is it because my knees hurt? Or is it because I'm short of breath, right? And short of breath would be more of a functional assessment of, I can't do that because of me being short of breath, right? Versus
absolutely,
having like knee pain or something.
And then that impacts quality of life and ability to be independent in the community, which is most people's goal. But I love our conversation as it relates to psychological concepts as well, like the women are socialized to hit a certain number, right? Yes. And then the body shaming and body image are very important. But a certain number does not get at this functionality, muscle,
We're feeling better.
Exactly.
Right? That's really what we want to do.
Not being out of breath.
Better. Yeah. And so I think it's super important. Women have been, I think, socialized for a long time too to be dieters.
Yes.
And unfortunately, and I think that layers on top, we're gonna talk about it later, but layers on top of when we give people a medication that can help them to eat less. And we've been telling them for decades to just eat less and exercise more and you'll be fine.
Right.
And then we give them this tool that allows them to eat less, then they just run around and don't eat.
Right.
And that's not what we want to do.
Right.
We need to eat regular, we need to fuel our bodies, right, with nutrition.
Yes.
And we have to find that balance, as you mentioned.
Absolutely. Thank you. Dr. Starr, why is an interprofessional approach so critical in managing obesity for women as they age?
Yeah, and I think we've already touched on it from the standpoint of the multi-complexity of obesity and also the psychosocial components that we have with women's health and women in particular. So I have had the wonderful privilege of actually working in an interprofessional team, and it has changed my practice as a registered dietitian of understanding how we together are so much more. And again, I always like to put like the wheel or a spoke of a bicycle in the spokes, and we have our women with obesity at the center of this conversation, and then we have our disciplines that come out of that. And then we have the tire that connects all of us together. We're not just individual, we're not just little blobs over here and we're not communicating, but that interprofessional team means that we're all working together, really focusing on our patient. And what I find to be very important is, obviously we have our PCP and having those conversations, and GSA created the Care Toolkit, which really gives a lot of resources for our healthcare providers on actually how to have these conversations with our patients about obesity and really starting that conversation, kickstarting that conversation. But that PCP really, helps kind of bridge this together. But then we have our registered dietitians who can actually provide medical nutrition therapy and should be providing medical nutrition therapy, or, being able to actually walk our patients through how we're supposed to be meeting these nutritional goals, what is actually happening to our body as we get older, why we need to be thinking about how we can spread protein throughout the day, or really making sure that we're getting in adequate fiber and fruits and vegetables and whole grains. And so again, being able to actually provide that versus just saying that. And then again, from our standpoint, and when we think about, and again, thinking about my patients, the number of times they talk about their knee pain, right? Our knee osteoarthritis and the relationship with osteoarthritis and weight. So really being able to think about our PT partners, our exercise physiologists, our individuals who have experience with older adults who are specialized with that, and our personal trainers, thinking about how we can actually help our older adults move better and have that expertise to support them. So I'm going to finish this up with our occupational therapists are so key from this as well. We know that many people have they have a hard time even standing up for long periods of time. So even thinking about how our occupational therapist can really help them in this journey, and as we're trying to get them to be more lean, not necessarily lighter, how we can actually start really building that strength with our patients. And I want to make sure I hit on our social work as well, our social workers as well, thinking about those social determinants of health. A lot of times we prescribe all of this, we give our patients all of this information, but we don't necessarily take it to that next level of really thinking about, do they live alone? Can they actually prepare meals? Do they have money to prepare their meals? Do they have the transportation to actually get this or move their body? All of these things are so important. Or if we're giving them a medication that has to be refrigerated, do they actually have refrigeration? Again, really, that is so important as we're having these conversations and we're hoping for the success and meeting that patient and really helping them get what matters most. And then finally is the psychology, behavioral science piece. We have to be able to figure out how to keep people not only being able to continue to, not only having that initial weight loss, that behavior change, but how do we actually help them maintain that? We know that weight cycling occurs, and we also know that that leads to more decline in physical function and loss of independence. And so we've done a great job. Research has done a great job at showing we can help people lose weight. And these incretin mimics are doing a great job at showing we can actually create weight loss.
Yes.
What we do not do a good job of is how do we identify when do we need to slow or stop that weight loss, and then how do we help people maintain that weight loss?
We have to help them. They have to stay on medication. And
absolutely.
Right? And that's what we like.
Yes.
That there's a lot of discussion right now about, which is that people can stop medication. And if you're going to use a medication to achieve weight loss, right, you have to continue it to keep it off, right? And that's what I think people have to, we as a society have to absorb that because there's been so much stigma and bias around weight that it is just about your fault and that it's only about the fact that you should just eat less and exercise more.
100%.
That we're struggling against that mentality, and we have to really, because like you said, it's so important to not gain it back. And so people have to understand that if they're going to do that, and that's their tool that they're using, that they have to continue to use that tool, likely ongoing. It doesn't mean you can't come off of it, see what happens, and go back on, but you have to do that before it gets
absolutely
too much back on. Right?
It's a chronic health condition, right? We have to continuously treat this chronic health condition. It's not like we just can come off.
But we've never treated it we've said it's a chronic disease.
But we've never treated it.
But we've never, because our system, is not set up to do that yet. But it will be now, I think. I mean, moving forward, I think it'll do that.
Yeah.
I certainly hope so. I love this conversation and the idea of this sort of like moral failing. That if only you had enough will, then you would reduce your, intake and maintain.
Do you understand the number of times I've told people this is not your fault and they start crying?
Yes.
Because if you imagine, like, I have one patient who is in her 70s, and she went on medication and has been successful, with her weight loss and her weight maintenance. And she said to me, she goes, you know what? I've been trying to do this for 50 years. And imagine doing something for 50 years and getting the same response. Right? That's the definition of insanity.
It is.
When you do the same thing over and over again and you get the same response, which is I lose weight, I gain it back, I lose weight, I gain it back. And now she finally has a tool that's helped her to be able to take this weight off and maintain this weight reduction. And she's like, I've been trying to do this for 50 years. I'm like, that's very profound because
that is moving.
But there's a lot of, to your point, there's a lot of trauma in that, right? That you got to unpack, that people have to unpack. Because if they don't unpack that trauma, then, it gets distorted.
And we know,
things happen.
Right? Food is about community. It's about family. There's so much emotional components that go with food. And so again, it is so essential to make sure that we can start unpackaging that piece. It's 1,000% of it. We need that piece.
Yeah, and being from the Southland, food is love.
Food is love. Food is love. Yes.
Dr. Fitch, clinical guidelines are often based on research in younger populations. So what specific adjustments are needed to make current obesity guidelines more appropriate for aging women?
Well, I think we actually need guidelines for older adults. I think we're coming to that point where, and women in particular too, but that we need guidelines around this as to how we're going to, as you mentioned, how far should we go? How low should we go? What is increasing people's risk, from a weight loss standpoint, and what should those guidelines be? And so I would encourage the GSA and the OMA, for example, to work together to form some of these guidelines for older adults, especially as we have all these new treatments that are coming forward that produce a substantial amount of weight loss, similar to bariatric surgery. And so, we really need to have some guidance there, in place. I don't know of any other guidelines for older adults. I don't know if you know of any.
I know that GSA Care Toolkit.
Yeah.
Yes, thank you for mentioning that.
Yes, which is a very easy to navigate toolkit for primary care physicians and all physicians, all providers around the United States and even worldwide that can give us appropriate advice as how to kickstart the conversation, what is the most important for the patient, for this woman going through menopause, what is the most important for her, how to assess what she's going through. Because as you mentioned, all the burden, the stigma, the bias, going into menopause, but also what if they have depression, what if they have anxiety, what is the behavioral and psychological component of it, and then how we evaluate and how we can appropriately refer. And going back to the interprofessional, interdisciplinary team, see how important all the pillars for the treatment of obesity are, like the behavioral component, the pharmaceutical component. So how can we integrate a pharmacist also in the treatment, and how to check all the medications that patient is taking, what medications are influencing.
Very important.
Very important. What other health conditions our patient has, this woman has, and also, as you mentioned, social determinants of health. So this toolkit provides how to evaluate appropriately and how to appropriately refer to.
I love that you mentioned the GSA Care Toolkit. GSA Care Toolkit, everybody.
Yes.
That's right. And I'll say, so again, I do think we're moving in the direction of really understanding that we cannot continue to leave older adults out of like our clinical guidelines, because we have done that so many times over and over. Even more recent ones they just kind of touch the surface. But I will say, ESPN and ESAO released their sarcopenic obesity recommendations right in 2022. So they're still, I mean, and again, I think we've had conversations about this. The Europeans are just so much further ahead.
They are.
And they're really thinking about this.
Especially
and
with sarcopenia.
Exactly. And so I think more and more we're starting to see recommendations and how we can actually take the research that we have and be able to actually put it into clinical practice. Because again, we know our systems are struggling right now. People are struggling. We're all tired as clinicians.
Yes.
How can we actually maybe take some of these sarcopenic F questionnaire? How can we take a hand grip string? How can we take questionnaires that actually are talking about what is it, how hard is it for you to do these activities? So I again, I think it's just a trickle, but I think if we look over to our European colleagues, we are starting to see more of this come out, which is exciting because guess what? We can collaborate. We can bridge that collaboration, which is great. So yeah.
Dr. Pendry, this one's for you.
Yes.
How effective are current pharmacologic interventions for weight loss in older women, especially given potential drug interactions? You were just alluding to this with common medications for hypertension and diabetes.
Yeah, so, right now, pharmacotherapy is the fastest growing treatment for obesity right now that we're seeing, and how incretin mimetics are just coming, and we are trying to prescribe every patient these medications because we have shown through clinical trials that it helps with cardiovascular risk reduction, like the semaglutide, also how it improves chronic kidney disease, how with weight loss you improve your systolic and diastolic blood pressure, and how you can slowly prescribe patients from their medications, but also with the understanding that obesity is a complex disease that needs treatment all your life. So with these medications, we have to be very careful because we really want to achieve weight loss in our women, but we want to achieve a healthy weight loss.
Right.
And we have to change the stigma also, not only the loss of weight, but how we can shift that thinking of, oh, we're improving your health. With this weight loss, we're improving your functionality, we're improving your quality of life, we are improving your other chronic conditions, but we have to be careful and finding the sweet spot right between healthy weight loss, how to preserve muscle mass, and how to keep your functionality.
Absolutely. I appreciate as well your thinking about in the interprofessional realm, potential drug interactions and the role of geriatric pharmacy, right? Because
Absolutely.
so many times it's the pharmacist who has a better take on the 11 or however many medications our older patients might be taking. So
Yes.
really appreciate that. Dr. Starr, what specialized nutritional strategies, such as protein intake adjustments, are most effective for older women with obesity? And how are dietary recommendations affected by sarcopenia?
Oh, it's such a great question. And again, as we think about our interventions to really help treat particularly sarcopenic obesity, exercise and nutrition are at the forefront of that, in combination with some of the other tools that we have, like our incretin mimics, that we can start to incorporate. So from a nutrition standpoint, what we have to first understand, again, in thinking about those physiological changes that we've talked about, One of the other things that happens from a metabolic standpoint is we experience something called anabolic resistance as we get older. So anabolic resistance is really that resistance to actually stimulating muscle protein synthesis, or that ability to actually build muscle mass. Now, the good news is that the evidence has shown that we actually can overcome that. So what we have to do as we get older is actually consume more protein, a little bit more protein, to actually get the same effect on that muscle protein synthesis rate, which is exciting. So it's not that we can't get it, but we have to be very purposeful about what we're actually consuming. And so when we put that in combination with weight loss, it's going to be really key. We know that when older individuals lose weight, and really thinking about women and their muscle mass, when older women are losing weight, we know that they're going to lose fat, but they're going to lose a higher amount of lean muscle mass than if they were younger. We know that. There's times and times again we show this. And so again, what are the things that we can do to help try to slow down that progression or that loss of muscle mass? And this is where protein becomes so key. One of the other things that we also know is that it's estimated that around 47, almost 50% of people, older individuals 65 and up, are actually not even meeting the 0.8 grams per kilogram of body weight, so that recommended dietary allowance. So we're not even getting the amount that we need. And then what the research has shown and what we're finding is that it's estimated that older individuals, especially those with multiple chronic health conditions or those who are with obesity and are trying to lose weight, their protein needs can go up to 1.2 to even 1.5 grams per kilogram of body weight. So as we're thinking about the pillar of nutrition, protein becomes at the forefront, and that can be both animal-based and plant-based. We just want to be thinking about high-quality protein and complete proteins. And then from the other areas that we need to be thinking about is also around the impact of weight loss on bone health. So are they getting in adequate calcium? Are they getting in necessary vitamin Ds? Make sure we're actually assessing that vitamin D, asking our patients how much milk they're actually consuming, right?
I laugh because you can't get a vitamin D covered by Medicare unless they have deficiency. But you can't know if they have a deficiency until you check the level.
That's insane.
Right?
It's so great. See, insanity.
Insanity. Yes. I mean, and we live in this, right, on a daily basis. But we're breaking it.
So I just put vitamin D device figure they're all deficient. So
and I think that's it, right? Because we know vitamin D deficiency it's so much higher in our older patient population. And so again, I think that's a really key piece as well. And then the other pieces are around that whole grains, fruits and vegetables, making sure that we're getting in adequate micronutrients and fiber. What we know is that when we start to lose weight, we're reducing that calorie intake. If we're on the incretin mimics, appetite is being suppressed. And so with that, we can expect to see micronutrient deficiencies. Mm-hmm. So I think having conversations, but really thinking about how we can actually integrate a multivitamin in there is really important. We very highly likely need to be supplementing with vitamin D. And then if they're not consuming enough calcium in their diet, we also need to be thinking about the calcium and vitamin D supplement together. Yes. So it is really important to be thinking about all of these components from a nutrition standpoint, but we can't just regurgitate this to our patient and expect them to be able to just take that and run with it. We know that most older adults have 1 to 2 meals per day, even those with obesity, which I know may seem shocking. And so again, how do we help them change how they're eating, that eating pattern? It's never going to just change immediately. And so again, thinking about the Treat and Reduce Obesity Act, being able to actually get registered dietitians covered, being able to actually get exercise physiologists covered, being able to actually get psychologists covered in intensive behavioral therapy is so important when we think about obesity, managing obesity, and helping people maintain and control this disease.
100%. And Dr. Fitch, I do want to get back with you about the advocacy efforts, but also thinking about health literacy and behavior change. You have this incredible mnemonic.
I don't know how about protein. We gotta have P's, right? Because P is protein, right? So it's planned portions of plants and protein, right? So the idea is people make it all too complicated. And you go on the internet, you're watching something on Facebook or Instagram, and it's like, you got to do this or don't eat this, and it's like, oh, it's too complicated. So patients come in all the time confused. I'm like, no, you just have to do planned portions. So you have to eat regularly. Don't just skip a meal, because like you said, they've been ingrained to be dieters. So
Absolutely.
they've been told in their
Exactly.
mind, don't eat, don't eat, don't eat. And then all of a sudden we give them a tool and they're like, well, I'm not supposed to eat. And I'm like, no, you need to eat. Like you need to force yourself to eat, and it's not
Right.
logical.
Yes.
Like when you're
Exactly.
trying to lose weight to say, I gotta, drink this protein shake or eat this yogurt or
Yes.
whatever protein. So plants and protein. So just say to yourself, am I having a plant? Am I having a protein? And sometimes we need to educate people on what those are, give them examples,
Yeah.
right? But if you're having a plant and you're having a protein, sometimes they come in the same package, like beans. Those are plants and protein. But you look in the fridge, you go, what do I want to have for lunch? Okay, I need a plant, I need a protein, and
It's perfect.
I love that.
Yeah.
I mean, the other stuff can come in there too, right?
Yes.
We talk to patients a lot about crowding things in instead of cutting things out.
Love that.
Because all the time, people, again, have been trained to cut things
Yes.
out.
Yep.
Like, it's just bad for me to eat that.
Yep.
That's bad. Don't eat that. Instead of, like, eat more of this, right? Like, this is
Right,
not
right,
really about eating less of that. It's really about eating more of vegetables and
Right.
more protein, right?
Right.
And, from a healthy nutrition standpoint.
100%.
Now, I'll give you a few more P's. See, there are 5 P's, and I put them together because 5 is one hand. So this is me telling people lifestyle stuff because I'm a primary care doc. I'm in a hurry.
Yeah.
I got to remember what to tell people or how to educate them. So I put planned portions together. It's 1 P. Planned portions, plants and protein, and then I add power, pillow, and pause. So power is for strength training. Pillow is for good sleep. We haven't really talked about
Yes.
sleep,
Oh,
but
yes.
sleep, I think, is so integral. And
Underpins.
when we get
Absolutely.
older, we don't sleep. And when we have menopause, we don't
100%.
sleep. And it's like a hot mess. And all of that can lead to inflammation and
Yes.
heart disease in and of itself, right? I mean, so
Absolutely.
pillow for sleep and pause for mindfulness.
Oh,
for
amen. Mindfulness.
pausing,
Yes.
for also not eating in the nighttime.
Yes.
Like, so, we're not circadian wise. There's a connection between our circadian rhythms and our adiposity,
Yes.
our excess body fat. So planned portion, plants and protein, power, pillow, and pause.
Love it.
Amazing. That is amazing.
And my friend told me I had to add P, like going to the bathroom.
Yes.
Because we
Yes.
should be
Well,
hydrated.
yeah.
'Cause I'm not
I love it.
So
It's the big P on the right here. You got to pee.
That's right.
you gotta keep peeing.
You gotta keep
That
peeing.
is right.
Love
You're
it.
hydrated.
That's right. Yes.
That
Yes.
is right.
Yes.
You say something about the legislation, though. I think that everybody
Yeah,
needs
so
to know
the
about
Treat and
that.
Reduce Obesity Act has been before Congress now for over 13 years, actually. We've been trying to get it passed. I've been advocating for that going for 13 years. During COVID, we did it virtually, but it almost got passed last year, and then that got taken away. But we did see some traction, recently that there was that next year in April we will have coverage for medication for obesity. So the Treat and Reduce Obesity Act was going to provide coverage, for Medicare for obesity medication, but also for the medical nutrition therapy, the intensive behavioral therapy that goes on top. So I think, unfortunately, without including that, we don't have coverage for the lifestyle piece
Right.
as we should. So we're still trying to advocate for that act to get passed because that would allow for medical nutrition therapy in particular, as well as other types of health coaching and counseling that would be necessary.
Absolutely. That's amazing. Thank you. Okay, so Dr. Starr, thinking about research and practice on nutritional interventions, I understand that you focus a great deal of your research on older adults integrating resistance training, which we've mentioned, into their routines. So what are the best practices for incorporating resistance training into weight loss programs for older women that might mitigate sarcopenia and bone fractures?
Yes, so it's so important, again, as we're thinking about, and I love power, right? Like we got the power.
Love power.
And so I love this. So as we have
can
our,
use 'em.
thank you, I appreciate it.
Copyright.
Yes, we're gonna get a patent though. So really kind of, again, we got our patient in the center. And in geriatrics, right, we always are thinking about what matters most. getting really at the heart of what matters most for our patients. And so as we're thinking about that, when we actually ask our patients what matters most, a lot of times we hear from them, it's, I want to be independent, I want to be able to play with my grandchildren, I want to be able to go and travel, I want to be able to get down on the floor and get back up. I want to be able to walk upstairs. And so when we are thinking about this weight loss trajectory and the impact of aging on our muscle health and our muscle strength, we really have to understand that we have got to support that muscle. And it is so important to be doing strength training. Many times when we are with our PCPs, we oftentimes hear them pushing the aerobic exercise piece, which again, very important. We know based on the CDC guidelines, we need 150 minutes of moderate physical activity per week. And so again, that's really key. But also on that other area of our CDC recommendations is that we need to be doing 2 days of whole body strength training. So all large muscle groups, 2 to 3 sets, and we need to be doing 8 to 12 repetitions of that, with the last few repetitions actually being hard.
That's key.
That's really key. And
People don't do that.
No, we don't. We don't challenge that muscle. We know that when we challenge the muscle, we break the muscle down, and then that allows that muscle to build up even stronger. And I think one of the key points that I try to always, speak with my patients or my clients or my research participants is fully understanding the why behind what we're recommending.
Yes.
Why are we recommending this? We're recommending this because this builds our foundation for being able to continue to function and not have as detrimental impact. Work by Dennis Villarreal really showed us that when we actually add that strength training piece and aerobic exercise piece, but really that strength training piece, we preserve lean muscle mass, we reduce that impact of loss of bone mineral density, we improve functionality. And so it's just such a powerful thing. So big takeaway here is when we're actually thinking about implementation of strength training, we really need to be thinking about things that are, how does it meet me where I'm at? Mm-hmm. So again, we talk about knee OA. A lot of times individuals have knee OA, and so being able to do a squat might be very challenging to do. Mm-hmm. So how can I sit in my chair and even just start as a starting place as a chair and being able to even just lift up my legs, extending out, meeting patients where they're at is going to be key. One of the other pieces that I really want to emphasize too is the fact that we can start, we can start where you're at. I think we have this image of somebody having to lift really heavy weights and being in a lot of pain or being in a gym setting. It can be our own body weight. Mm-hmm. And that is so important too. And I think, again, giving people the understanding and steps that it just if we can just start today, if you can just do a little bit today is where we want to be. And again, like the last piece I always end with is with my patients is like, if I ask them, hey, can you do a push-up? And they're like, of course I can't do a push-up, right? I can't do a push-up. And I'm like, well, let's go against the wall here. And let's push ourselves against that wall. Now, what is this mimicking? This is mimicking even opening up a door. So functional movement patterns. Mm-hmm. How does this mimic our everyday activity? And so again, just really being able to identify programs that are more personalized, individual programs that have more of a group setting that help you support, really that support system, the accountability. I'm going to show up. Anything that we can do to help really build that piece, I think, is so key. And then how we can continue to challenge the muscle. So being able to actually track our progress over time, to be able to say, oh, I'm getting stronger. I could probably go up. I could probably go up in a little bit of weight. So again, all of those.
Trainer.
Yes.
Because I don't do it on my own.
You won't. It's very hard to do it on your own. Yes. And so again, that group support is really key. So yeah, I love. Again, we're just in this wonderful time where we have these new drugs, we have the nutrition piece, we have the strength training piece. We actually have, I think, women's health is at the forefront. We actually have women who are like, I got to prioritize myself.
Yes.
I'm in the sandwich generation. I have to start thinking about myself. And I think we're turning that lens around from where it was, I don't have time to think about myself because I'm having to deal with children and my parents, and putting that mirror back and saying, no, I got to think about myself so that I can provide better care to my children and my parents. So,
100%.
It's very exciting.
Yes.
If you can't tell.
It's so fun. And, women, we're the hub, right? We're the hub of that wheel.
Yes.
And if we go down, then the whole system goes
It
down.
does.
And we just can't afford to do that, right?
Yeah.
So I love that, meeting patients where they're at. I mean, every bit of it.
Yeah.
And the motivational component, the interprofessional, psychosocial, nutrition, medicine, all of it.
Yeah.
So Dr. Fitch, thinking about that lifespan perspective, right? So what are the key considerations managing obesity for women who experience late in comparison to early menopause?
Well, I think, as was mentioned, we should definitely be helping women understand these things even earlier, even before perimenopause,
Yes.
so that they can start to make some of these changes earlier so that they're not doing it during menopause, right? But, someone who's gone through menopause earlier, you're going to be more concerned about bone health and about, other factors, other risk factors. So that person may be someone you would, treat with hormonal therapy earlier in order to preserve that muscle mass, to preserve that, to decrease that risk of that development of visceral adiposity. If you develop that at the age of 45, it's a lot different than developing at the age of 60,
Yes.
depending on where in that spectrum you fall. So I do think, looking at the whole person is very important, especially as we look at that menopause transition, because none of our studies on weight management have looked at that menopause transition. And I've been encouraging all of our, there are over 120 new drugs for obesity in the pipeline at the moment. It is, as you
120.
mentioned, it's like the biggest, and there will be drugs coming out in the next 10 years that preserve muscle mass, right? Where you can only lose, you're only losing fat mass and not losing muscle mass. This is being researched. So, but that doesn't mean we can just be like, oh, there's going to be a new drug for it.
Let's do whatever we want.
But we still have to encourage these healthy behaviors,
Right.
and then look at where does menopause or hormone therapy fit in, right?
Yes.
Because we went, when I was first starting in practice 25 years ago, we would take women from OCPs to HRT or MHT now as we're calling it, right? We would just transition them automatically at 50. We would just switch them over because it was good to stay on those hormones in order to prevent heart disease and diabetes, et cetera.
Right.
And then what happened is the Women's Health Study came out, and then everybody went off their hormones. And it was like we swung the whole other direction.
Yeah.
And now I think we're unfortunately seeing some ramifications of that in our women, that have aged throughout that, right?
Mm-hmm.
And so now I think it's becoming much more of a focus, as you mentioned, that women are getting back into that shared decision making and that risk benefit analysis, right? For me, like, what's the risk of losing weight? What is the risk of not losing weight, right? And what is how do we fit that all together in my menopause transition and my aging transition?
Absolutely. What do you guys think about these microdose? Okay, I have an eye roll here. So, Noom and these popular, programs available to whomever, whatever, online for a small fee. Talk about exactly. So talk about that.
I don't like the word microdosing.
Okay.
So we should, even though it is a meaning technically speaking, semaglutide starts at 0.25 milligrams.
Right.
That's the starting dose. That is a microdose. so technically, because it's 0.25 milligrams. It's micrograms of the drug, but it's an effective dose. It's a treatment dose. It's a dose. Okay. I think the idea of microdosing came out of a community of people that were doing things subversively in order to attain some sort of benefit, whether that's being leaner, whether that's being having some sort of health benefit that hasn't been proven yet. We know these drugs are being, I'm glad you brought that up, because we know these medications are being researched for Alzheimer's, for Alzheimer's risk reduction.
Yes.
And which is very, important for aging people
well.
in general, right? But we don't have that data yet. So to be offering it at a population health level and almost an over-the-counter, approach of getting it, I think it's too risky right now. We don't know and again, I like to think of it as not a microdose, but the appropriate dose for that patient.
Oh, I like that.
Because some people, it's just the dose. Like some people, if I take lisinopril, for example, for renal protection of my kidneys, I might not only need 2.5 milligrams, which is a very low dose of lisinopril, right? But I don't call that microdosing lisinopril.
Interesting.
I'm taking a dose of lisinopril that doesn't cause me to pass out, like 'cause I might not have hypertension, I'm just taking it for renal protection.
Yes.
I take a certain dose, right? And I think the same is going to be true of these medications as we move forward. And so I'd like to get away from, because again, microdosing makes it sound like subversive or something. Like
Interesting.
and it was because
Yeah.
that started to be honest, it started in the bodybuilding and in these arenas who were microdosing this medication, like somewhat inappropriately in order to look a certain way, for some sort of competition, So again, I think that we should talk about appropriate dose for the patient for that condition.
Patient-centered.
But right now we don't know that 0.25 of semaglutide does anything for you if we're not looking at weight reduction, for example, or diabetes control, like for that medication. So that would be the outcome, right, that we'd be looking at. Because there may be patients that will lose significant weight or have diabetes control at 0.25 milligrams.
Right.
But that's the dose that's important for them for that indication, right?
Right.
And right now we don't have an indication for longevity. We don't have an indication for Alzheimer's, brain health, memory,
And
fog.
substance use. People are going absolutely extreme about the use of GLP-1s for addiction.
We need this research, though. I mean, that's the most important thing. But the most important thing is we should base our practice on evidence. I think.
Yes.
Right,
Yes.
and not on not on. And now on a one-off case-by-case basis, I think there are appropriate uses for these medications in an off-label fashion for individual patients. But that should be at an individual shared decision-making level,
100%.
not at I can fill out a form and I can get something off the internet that's not even the real drug either. So we have to take that into account. Because not only are we giving people, a large percentage of people, this potentially off-label, but we're also doing it with drug that hasn't been studied effectively. It's not FDA approved. It's not, meaning the compounded things that are being delivered in that manner because of cost. We do not know the safety, quality, and efficacy of those because they're not regulated in that manner like the FDA approved drugs are. So I think it's got multiple layers of complexity there that I would not trust my license around. Meaning as a medical professional, that's a lot of risk. There's a lot of unknowns. We usually, what I say is, we're doing the largest uncontrolled, unconsented human experiment of our time. With some of these things that are being offered, because again, it's an experiment to do that, right? And we should be consented. I mean, if you're consenting people and you're doing a research study on that approach, good, we should do that, right?
You should know risks, benefits.
But you should know as a patient that I don't know what this stuff is that I'm putting into my body, and I don't know if it's going to hurt me. I don't know if it's going to help me, but you're going to research it. And that's what we do in clinical research. But we can't be using it at a population level when we don't know the data.
100%. So I will put in a plug, everybody, for more funding. Don't forget National Institute of Health. We like science. GSA likes science. So we need funding.
And I think what you're saying is built on evidence. And unfortunately,
100%.
The studies that we have do not have a large number of older adults, right?
That's right.
Particularly around weight loss, right? Just weight loss itself. There is a paucity of data that we just don't have it. And we don't have, it's not even the older adults themselves, it's the functional outcomes, the muscle mass, what's actually happening from that standpoint. So again, and then thinking about responders and non-responders, or people who can respond at 0.25 versus, again, like understanding understanding our older adults who are very heterogeneous, our older women who are very heterogeneous, and understanding how these drugs can be utilized and really thinking about the safety of that for long-term function. So
Yeah,
yeah,
100%.
just again, a plug for funding.
Yes, and we have to be very responsible of what we are prescribing, what we are trying to educate our community, and also, like right now, based on evidence, medications that we are prescribing, knowing and educating our community, our women, empowering our women with the 5 Ps about anti-obesity medications and their side effects. As you were saying, like we have to make sure that our women are eating correctly, that they can access to the food, access to the protein,
Absolutely.
and also what side effects they have if they are consuming enough fiber, if they're drinking enough water. So we have to be very socially responsible on what we do.
Yes, yes, yes.
Absolutely.
Yes.
And also maybe distill information in bite-sized pieces,
Yes.
so to speak. Like
Yes.
if it's bite-sized, then our
That's another
patients can
piece.
Another
understand.
piece.
There you go, pieces.
Pieces.
Six.
We're gonna have our
Well, I know that we're getting close to time here. So in our final minutes together, I'd like for each of you to share your thoughts on what's on the horizon for obesity care for aging women. So your like top most thoughts about innovations, resources, therapies that you're most excited about in obesity care, and how they might improve quality of care and quality of life with aging women. Dr. Pendry, let's start with you.
Okay, I'm very happy because this is an opportunity for our community also to learn about the GSA Care Toolkit for obesity care and cognitive impairment care. So we have to find ways to promote education to our providers and the community as a whole on easy ways to empower them to know when they go to their provider what they can ask for and what is their goal. And we have to treat our patients according to their goals. We have to align our treatment according to the goal of the patient. And so it's I see in the horizon that education, empowerment is something that is coming. And it's already there, but we can empower it further. And also, I see that we have this anti-obesity medications and incretin mimetics, which this is a great opportunity, as we were talking, to have big organizations to fund research in older adults,
Yes.
to fund research in outcomes, in function,
Yes.
in functionality, independence, and quality of life.
Well done with those community-based partnerships too,
Yes.
in industry partnerships. Dr. Fitch, what are your thoughts?
Well, I would say, in similar fashion, I'm excited about the advancements that are coming forth, for obesity care, and in particular, how that relates with the menopause transition, because it is a group of obesity research has mostly been women's research, but we just haven't shown that enough, right? And it's by accident, if you will, because it's most people. Like in our clinic at Knownwell, 70% of our patients are women, right? And the average age is 45 or something, or 46. So, I mean, we're essentially a women's health clinic,
Yes.
Disguised as a metabolic health and primary care center, right? But women, as you mentioned, are driving all of that,
Yes.
right? I mean, driving their spouses a lot of times to come in and, driving the whole ship. So, again, I'm really excited that we will have more and more treatment options, and that I do think a lot of those treatment options are spending more time now on, where do they fit in the treatment spectrum. And so we're going to have more of that personalization, right? More of that sort of as you mentioned, it's really obesities, not just obesity, right? It's not one disease.
Right.
So if you picture centuries ago, when we had probably one cancer treatment and we had all these cancers, and so we only had one chemotherapy,
Right.
so we were giving people one chemotherapy for all these cancers, and now we have multiple different treatment options, and we know that if you're a woman with breast cancer with these markers and this thing and this, that precision medicine I think is really going to increase over time.
It's another P.
Another peak.
7
Precision
Ps.
and personalization. We got 10.
Yes, we got 10.
Okay.
Yeah, and again, just echoing my colleagues here on you can feel the energy around women's health, and it is exciting, and it's way overdue.
Oh, yes.
So overdue for the fact of really thinking about women's health. And I think we're at this precipice of really trying to fully understand the menopause trajectory and how that plays a role on what happens in postmenopause, and how we can actually start really personalizing this treatment pattern, plans of where we're going to intervene, how much we would intervene, and really understanding again that who responds, who doesn't respond. If they don't respond, what's the other interventions that we could actually integrate? Why aren't they responding? Instead of just saying, oh, you don't have the willpower to do it.
Yes.
Right? Really being able to get a tailored care that focuses on the person, the heterogeneity of that person. And it truly is, it is just so exciting to be here right now in this arena. And I think, again, the last piece I'm going to say is around the differences in race and ethnicity.
Oh, yes.
Oh, yes.
We are lacking
too.
a full understanding
yes.
of
So much work to be
Evidence.
done.
so much work to
Yes.
be done, and truly understanding how does that muscle change? How does that energy expenditure change? What is actually happening from a metabolic and physiological change that differs by race and ethnicity? And so again, I think in the next 10 years, if we can continue this momentum in women's health, the horizon is very bright for this area, and really trying to be able to make some changes in women's health and give women options. And that's just so exciting. So just really, it's an exciting time, and I love all the work everybody's doing in this space, right? And we're actually finally coming together. It's just great. So really, really excited about that.
This really has just been such a fun time to talk with you guys and get to know you. And it is an exciting opportunity for all of us to work together in an interprofessional way to improve women's health across the lifespan, but particularly midlife into the very old age. So thank you. Thank you so much, guys.
Thank you.
Thank you.
Thank you.
Thank you.